Scheduled, so I have to be somewhere else at a given hour. We are an hour and 9 minutes late, and I do apologize for that. However, I won't promise that we will make up any of the lost time, but I will promise that we will finish on time. As we were supposed to have an hour, we will have an hour. And I will try to keep us on time. So, with that, I think I'd like to get the session opened and started. So, we have 3 talks this afternoon for you, and they're all about surgery, surgery being the first line of treatment for neuroendocrine tumors. Our first speaker this afternoon is Dr. Philip Boudreaux, who is the professor of surgery at LSU Health Sciences Center in New Orleans. And he is professor and vice chairman of surgery in the Department of Surgery at the Oxnard-Kenner Hospital. Dr. Boudreaux?
Good afternoon, and it's a real privilege to be here in this part of the world where I'm parle français de temps en temps. And so it's been fun so far. I want to talk to you a little bit today about pancreatic surgery. I truncated this talk a little bit in the interest of time, so we may not touch on every single issue that centers around surgery of the pancreas, but I hope to at least give you some ideas and open a few doors to some possibilities and maybe give you a picture of what at least our perception is of pancreatic surgery for neuroendocrine tumors. In general, we find that half of the pancreatic tumors we run into are non-functional, which means they don't secrete a peptide, they don't secrete a hormone, they don't secrete a compound that does anything that makes you feel a certain way or causes a set of symptoms. So we call those the silent tumors. And about the other half of them are physiologically active. They'll secrete something that makes you have a problem. Of those, probably the bulk of them, of the ones that are secretagogue tumors, are going to be the gastrinomas and the insulinomas, by far and away, seem to lead the pack. We're not sure why that is, but it's sort of an interesting phenomenon. And then the remainder being the VIPomas, glucagonomas, somatostatinomas. We'll talk a little bit about those as we go. So, just looking at some of the different things involving pancreatic surgery, when we're looking at functional tumors, let's start with, say, the insulinoma, being the most common. A high insulin level, as you recall, will cause a precipitous drop in blood sugar, and these folks need to eat and nibble all the time. They have to be awakened at night while they're sleeping and made to go eat something so they don't get hypoglycemic with a glucose of 5, and by the next morning they've got some Dane-Bramage. So it's a very dangerous condition in some of these folks, especially when they don't have hypoglycemia unawareness. I mean, when they have a hypoglycemia unawareness, that means they have no sense of when a low blood sugar attack is coming. They don't get a cool and clammy feeling. They don't get any of the signals that diabetics many times will get that says, I better go eat a candy bar or eat something sweet or get some kind of food in my system. They just go to the ground with a precipitous fall in their blood sugar. The majority of these are what we would call, in the old classification, benign or well differentiated, but a fair number of those can metastasize and can be quite lethal. We usually find an extremely high fasting serum insulin level, and because low blood sugars can be extremely dangerous, it's usually a supervised fast up to 72 hours, and they usually have an IV in place, so this is done in the hospital, so that if they do experience a precipitous drop in blood sugar, we'll grab a blood sample right then to send off for an insulin level, which would be disproportionately high to their blood sugar, and then we give them some intravenous glucose or something to raise them up off the floor. Some of the other tests we used to use would be the plasma to serum C-peptide ratios, and sometimes that's helpful. But I would say probably the fasting serum insulin level is the most commonly used. And to image these tumors, they're sometimes very hard to see. Sometimes they can be very small. And so the newest trick on the block is the, I guess I got to give equal time, don't I? Endoscopic ultrasound to find these tumors in the pancreas is a sensitive way. Other times you have to use a hand scan, and you can find them by feeling. And you can use intraoperative ultrasound placed directly on the pancreas if it's an open procedure. Other times, selective venous sampling, which is extremely difficult to do, to find out where the elevated insulin levels may be draining from in patients that have very small tumors. Now let's shift gears to the gastrinoma, probably the next most common functional tumor of the pancreas. Elevated levels of gastrin can cause ulcerations in the stomach, the duodenum, and sometimes other parts of the proximal small bowel from just oversecretion of acid. Gastrin is the on switch in your stomach for make acid. About half of these can be malignant, and a fourth of these, of that group, are associated with the MEN1 syndrome or multiple endocrine neoplasias. We'll talk a little more about that. You could spend an entire hour talking about MEN syndromes, but we won't go into that in great detail today. Now, why do I say that the fasting gastrin levels should be measured without the use of the PPIs? Well, PPIs, the proton pump inhibitors, Nexium, Protonix, Pepsid, the purple pill, Acifex, those are in that group. They are very good drugs to turn off gastrin secretion, turn off acid secretion. The normal reflex in the stomach is, I don't sense enough acid, I need acid, so send some gastrin down the pipe to turn on the acid cells. And so they'll have an artificially elevated gastrin level because they've done such a good job of shutting off the stomach acid production. So we want to have the PPIs off the table for a while, then we can measure the serum gastrin levels, and we usually end up doing a stimulation test to really max out gastrin release and gastrin production. We don't usually use calcium infusions anymore. We just watch the secretin after the infusion of secretin, and we'll see what happens to the gastrin levels and sample frequent blood sugars afterwards. The funny thing about these tumors, or the interesting thing about these tumors, is that probably 8 out of 10 of them are located in a certain region of the pancreas called the gastrinoma triangle, and somewhere in here between the bile duct area, the duodenal area, and the head of the pancreas, and the last part of the stomach is where you often will find these tumors. They are often multiple, and so the surgeon has to be aware that just because you found one doesn't mean you're done for the day. You better keep looking because maybe there's 2 or 3 or 10 or 20. For imaging studies, endoscopic ultrasound is helpful, but sometimes these tumors, even though they are small, can light up on an Arctria scan, and typically Arctria scans are not that good for small tumors. Now, the VIP, which stands for Vasoactive Intestinal Polypeptide, about half to 3/4 of those are going to be malignant, and they cause the WDHA. We like a lot of acronyms and abbreviations in medicine. Sometimes I think we use them a little too much. But watery diarrhea, hypokalemia or low potassium levels, achlorhydria means not enough acid in your stomach. So these people might have elevated gastrin levels as a surrogate marker for what's going on, but it's not that they have a gastrinoma, it's that their gastric acid has been shut off. Most of these are located in the pancreas, and why most of them are in the tail of the pancreas, which is the back end, I'm not quite sure why that is either. There's a lot of things in the study of neuroendocrine tumors that still has us scratching our heads and makes us look for more answers. A majority of them are metastatic when they present, and about 50% of these people can be cured with the resection. The multiple endocrine neoplasia, I'm just going to touch on it briefly. The MEN1, it's a rare inherited form of neuroendocrine tumor, tends to run in families, so if one person in the family has it, it's a good idea to start screening other family members. The 3 Ps are the parathyroid, the pancreas, and the pituitary, and that's where the endocrine neoplasia, or the overgrowth of an endocrine type cell. Did this thing just change volume, or did I just talk louder? At any rate, most of the patients are going to be symptomatic by the age of 30, but the abnormalities can develop in the blood between the ages of 10 and 30, and usually the first abnormality we see is an abnormality in the parathyroid with elevated levels of PTH, which can therefore elevate serum calcium levels. And it's at the expense of the bones. It's sucking calcium out of your bones and putting it into the circulation. So sometimes kidney stones are manifest as the tip of the iceberg for why these people have this syndrome. And then genetic testing is oftentimes in order if a family member has been diagnosed. And the majority of these people do get the parathyroid tumors, but they don't always get the other two, either in the pancreas or the pituitary. So it's an incomplete expression of a genetic disease. The functioning tumors, probably the most common type, and there's another thing that makes us go, is that if you're young, you're more likely to get an insulinoma, but if you're older, I won't say old, I said older, gastrinomas are more common. We don't exactly know why that is either. And just, if there's an MEN1, there must be an MEN2, right? So just for the sake of completeness, those are a little different. Parathyroid tumors can be common, and adrenal tumors, and cancer of the thyroid is also associated with that disease. Well, talk about another couple of less common types of pancreatic tumors, the glucagonoma and the somatostatinomas. Glucagon, majority of those, when we find them, are malignant. The majority of them are female. And again, there we have the 4Ds, the diagnosis of diabetes, dermatitis, which means skin eruptions, depression, and DVT, or deep vein thrombosis. They have clot formation in large blood vessels, which is not usual for most of us. Most of the patients are metastatic at the time they're diagnosed, and this is a rash that they get. And so, in general, they have a typical sort of body habitus, kind of pear-shaped, and diabetes is also problematic to control in these patients. Somatostatinomas, the majority of those are located within the pancreas. They're often metastatic, again, like the glucagonomas at the time of presentation. Again, the females outnumber the males 2 to 1. We're not sure why that is. And they're associated with other types of syndromes, diabetes and gallstones being common, as well as diarrhea and or weight loss. Well, the anatomy of the pancreas, just to talk a little bit about, when we talk about the surgery of the pancreas, we know something about what the pancreas looks like and where it lives. Well, Herophilus, back in way long time ago, about 300 BC, he was considered the father of anatomy. He was a physician, he had his own medical school, and he studied anatomy by studying cadavers, and it is rumored he may even did vivisection on people who weren't quite yet cadaveric. At any rate, he predated our current teachers of anatomy by about 1800 years, when Leonardo da Vinci and Vesalius sort of made anatomy a popular thing to study again. At any rate, the pancreas sits way far back in the belly. It's behind the liver. It's also behind the stomach, which isn't shown here. And also overlaying all that is the transverse colon. So it's way back here by the kidneys. It's a dual functioning organ. It has a pancreatic duct, which the pancreatic secretions are going to leave the pancreas right into the first part of the intestine called the duodenum, and they will have the enzymes in there to help with digestion of proteins and fats and carbohydrates, as well as bicarbonate production to neutralize gastric acid. We talk about the tail and the body and the surgical neck of the pancreas. There's a kind of a narrower part of the pancreas, which is typically a dividing line. The portal vein runs right under that, and sometimes tumors of this part of the pancreas here can invade that portal vein and make surgery for the pancreas a little more dicey. This is a biopsy specimen of actually a transplanted pancreas, but I wanted to show you that these little clearer zones here are called the islets of Langerhans. That's where the neuroendocrine cells live, and so an insulinoma would start in a little cluster of cells like this. These other cells here are the exocrine pancreas, and they coalesce they deposit their secretions in tiny little ductules, which coalesce to form bigger ductules and eventually drain into the pancreatic duct. So this is a double organ. It has endocrine function, releases all kinds of hormones from these little cells right into the bloodstream, and it releases its secretions into the gastrointestinal tract. Well, when you operate on the pancreas, sometimes you can open yourself up for a world of hurt by way of the enzymes, which can bite you sometimes because they can go away on digesting things you don't want them to digest. They can auto-digest your own pancreas. They can digest away your suture lines and result in leaks and other problems. The other reason we consider operating or not operating on the pancreas happens to be location. It's like real estate. Location, 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 which sometimes dictates the ease of the difficulty with which we can approach the pancreas from a surgical perspective. And sometimes if you're in the wrong place at the wrong time, as we learned a few years back, some bad things can happen. The surgeon has to consider the location anatomically, has to consider the risk of removal versus the risk of benefit, and then what are the long-term consequences of the operation you hope to perform in the global sense of how is this going to help this particular patient. Just because a tumor is in a resectable place may not mean that the best idea is to go to the operating room right now. Maybe eventually, but maybe not right now. Those of us who operate on the pancreas were thought to be a little bit out of our minds for many years, especially those of us who transplanted them and actually took them out and put them in someplace else. But we've sort of refined it a bit now so it's not such a scary operation. We, in our practice, like to use large doses of sandostatin infusion, not so much to prevent carcinoid syndrome in this particular case, although some patients can be syndromic, and we think it helps in the patients who have high levels of, say, insulin. It helps ameliorate their hyperinsulinemia. But the other thing is, remember that exocrine part of the pancreas can also be switched off by somatostatin analogs. So using an octreotide infusion to decrease the enzyme production may, in fact, decrease the leak rate and decrease the rate of pancreatitis, where the pancreas tries to auto-digest itself because it's mad at you right now because you just handled it and fooled with it and operated on it and sewed to it and done whatever you've just done. We use low filling pressures to minimize our back bleeding because the splenic vein, which runs along with the pancreas, connects right into the portal vein, which goes right to the liver, which goes right to the heart, and there's no valves in between the systems, so you can get a lot of back bleeding on the reverse end out of the pancreas you may be leaving behind if you're doing a distal pancreatectomy, for instance. And again, if the patients have a pancreatic tumor that's producing compounds, especially insulin, you have to monitor very closely throughout the operation for hypoglycemia, because as you're manipulating the tumor and working on it and squeezing it, you might release some extra insulin into the system. Extent of disease management of assessment. We use a lot of scans like everybody does. We use a CT scan, and this shows a patient who has tumor in the liver as well as some tumor in the pancreas pushing the stomach forward. And this patient was an individual who had recently retired and liked to ride the trains and lived kind of in the middle of the country and had good railroad service and liked to take train vacations, but then started having trouble with vomiting blood in the middle of these trips, and it kept recurring, and they thought the patient had a recurring bleeding gastric ulcer. It was a disincentive for her to take the train because she never knew what hospital she was going to end up in before the trip was over to have her bleeding taken care of. It ultimately turned out that it was a neuroendocrine tumor that lit up on the arteria scan, but you see it's kind of disappointing. We don't see a lot of activity compared to what we see. Nothing in the liver. Just this spot right here is about the only, this spot right here is about the only interesting thing on this scan that you really, this stuff cleared out later. It was just in the colon on a subsequent films. However, at operation, this is right after lunch, but this is her tumor, which was pushing up and eroding through the back of her stomach, and there was a hole in the stomach from this tumor. This is her spleen. It's about as big as my head, and these big, large, ropey things are big variceal veins, which also contributed to high venous pressures in the stomach and predisposed the stomach to bleed because the tumor had blocked the main vein draining the spleen, and the blood had to leave the spleen and have a place to go, and another shortcut back to the liver was by way of the stomach. Well, everybody talks about the Whipple, the feared Whipple resection. It's named after the guy Whipple who invented it and was the first person to get a survivor. And basically, for tumors in that head of the pancreas, that proximal port, what's going to happen is that because the intestine and the pancreas share a common blood supply, if the tumor couldn't be enucleated safely from this region and had to be removed with a portion of surrounding pancreas, you've lost the blood supply to this part of the intestine in general, and that usually is taken with the tumor. This operation was devised for patients with adenocarcinoma of the pancreas or pancreatic cancer. not neuroendocrine tumors, however. Sometimes the tumors, though, in the pancreas completely block the bile duct. Remember, the bile duct runs right through that part of the pancreas, and so the tumor wraps around it and causes obstructive jaundice, and that's sometimes the indication for operation. Well, you have to disconnect all this stuff from the stomach, from the bile duct, and from the downstream intestines. Then you have to put it all back together. So you're going to have a bunch of connections. Uh-oh, my light's dying. Here we go. You have to reconnect the pancreas, because remember that pancreatic duct, pancreatic juice has to have a place to go. Bile has to have a place to go, and it all wants to go back in your gut. And food has to have a place to go. The main risk would be pancreatitis or a leak from any one of these anastomoses would be a theoretical chance for a leak. With a distal pancreatectomy, most often now we perform what's called a spleen sparing rather than splenectomy along with the tail of the pancreas. The spleen and the pancreas share a common blood supply, but many times you can disconnect it off of the spleen, and the spleen can live off a shared blood supply it has with the stomach in many cases, providing the tumor is not invading the spleen directly or there are not metastases in the spleen, which we sometimes see. And usually just closing off the proximal end of the pancreas in a leak-proof fashion will be all you need to do, because it still drains normally through this proximal part into the intestine, and the pancreatic duct joins the bile duct and lets the pancreatic juice out into the gut. And sometimes these tumors in the tail of the pancreas can be very large. Last week we had one about that big. So it's amazing these tumors can get so large and present so late. Now, nucleation is another technique we sometimes use, and again, it's all about location. This can be done many times laparoscopically, where we're like playing video games. We're watching everything on a monitor screen with small instruments inserted through small incisions, and we can remove a tumor from the head of the pancreas. But if the tumor is in a wrong place, too close to the main pancreatic duct, or those main veins we're talking about draining through there, the portal vein particularly, then it would be better served with an open procedure. Major bleeding from the portal vein on the back side of the pancreas is not something you want to get into when you have 4 little keyholes and you need to get your finger in there and put a plug in the dike to stop the bleeding. So again, location is very important when designing an operation for pancreatic tumors. Total pancreatectomy is rarely done, but sometimes it is needed, where the entire length of the pancreas is involved. And you can sometimes get away with removing the entire pancreas without sacrificing this portion of the duodenum if it has enough collateral vessels from the stomach above, although usually it's not going to survive, and so that part of the intestine goes with the whole pancreas. Like the Whipple procedure, you still have to reconnect the bile duct and reconnect the stomach, but there's no pancreas to reconnect, so you don't have to worry about a pancreatic leak. And after total pancreatectomy, patients automatically will become diabetic and will need insulin. Many of them may already be diabetic if enough of their pancreas has been disturbed by whatever the disease process from tumor or other types of things, chronic pancreatitis and so forth. You don't have to worry about a pancreatic leak, but you do have to supplement with oral pancreatic enzymes to aid digestion. Now, in terms of which operation and when is it done, the timing of the operation, how big of an operation to do you combine pancreatic resection with liver resection or some other procedure? A lot of that right now in surgeons' minds is a matter of religion and conviction more than science. And that's because they don't have a lot of real good science telling us what is the best way to handle this particular problem with this particular patient. So we usually try to have a group growth, at least in our practice, and get more than one set of inputs to try and determine what is the best course of action for a particular patient with a particular problem. Overall, the survival for pancreatic surgery after pancreatic neuroendocrine tumors is around 60% and about 40% at 5 years. And this is somewhat of a mix of patients with metastases and without. Without metastases, obviously, these numbers go up. Again, it depends on the cell type, and we get into the classification. Are these a well-differentiated, looks like its sister, or is it a poorly differentiated tumor that's unrecognizable and it's just going wild and growing fast and a real neuroendocrine aggressive cancer? So that affects one's decision in terms of what type of operation the patient may be recommended. Age of the patient is also a factor. The grade of the tumor, we talked about that, and whether or not they have distant metastases. What's not quite as significant is whether the tumor makes some kind of juice or not. Non-functional or functional doesn't seem to matter a whole lot in terms of survival, but functional tumors that make something we can measure makes it a lot easier to follow the patients longitudinally to see for recurrence, to see what other modalities you're using. Is it controlling the problem, or is the tumor getting out of control and now you need to do something different because what you're doing is no longer working. We don't know for a fact the importance of Ki-67, but we sure think it's important. How well the angiogenic index, how well can this tumor make new blood vessels for itself to nourish itself? And if we can figure out maybe how to turn that off, instead of killing the tumor, we can starve it out by inhibiting its ability to nourish itself. When it metastasizes and goes someplace else, it's got to grow itself a new blood supply. If we can inhibit that, we can perhaps inhibit the metastases. And then whether or not chemotherapy plays a role. In general, it's going to be more effective for the faster growing, less differentiated tumors, and not as effective for the well-differentiated tumors. In our group, we usually follow the levels, like I said, of whatever active secretagogue, whatever the pancreas tumor might be making. We would like to follow levels of that. Chromogranin A seems to be a common denominator. Pancreatic polypeptide seems to be a common denominator, and oftentimes pancreastatin, so that no matter whatever else the tumor might be doing, silent or active, we can usually find one of these kind of markers to help us in terms of following the tumor. Postoperatively, the patients stay in the hospital anywhere from 4 days to a couple of weeks. Usually we'll leave a drain in the pancreatic bed, again, to kind of, if we do get a leak, we like to keep it a controlled fistula. Knock on wood, the leak rate is less than 5%, but being an older-fashioned guy, I'm more prone to use a drain than not, and that can sometimes be taken out actually after the patient is discharged. The pathology is reviewed again postoperatively because it may not agree with a preoperative biopsy, because many times a preoperative biopsy is a tiny little sliver, either a sliver of liver or a tiny little piece of pancreas. And so sometimes we have the whole thing and the pathologist says, well, this is really looking different. And so that may affect what other part of the treatment goals and modalities we may employ down the road for that patient. Nutritional assessment is very important, especially after pancreatic surgery, where pancreatic insufficiency may be subtle, may be occult, and may be compounded by the use of an octreotide or a somatostatin analog, in that less pancreas to make pancreatic juice, less pancreatic juice being made by the remnant pancreas because we shut it off with our therapies. And so patients may have diarrhea not because their syndrome is out of control, but they may have diarrhea because they don't have enough pancreatic enzymes to digest the fats in their diet, and those fats act like cathartics, like castor oil, basically. And so that has to be dissected out sometimes in people with recalcitrant diarrhea. We usually follow patients every 3 months with markers if they're available, and then every 6 months with imaging studies. So I hope that gives you a little bit of a picture of what pancreatic surgery can involve. I am fortunate to work with a great team of people who are all focused on this problem of neuroendocrine tumors, and we've just added a new team member. I hope you get a chance to come and say hi to. He's sitting right there. His name is Saju Joseph. He's a West Coaster who then got educated on the East Coast and even spent some time on the far East Coast over in Scotland. And so now he's seeing how it feels to have mud between his toes. Anyway, thank you for your time, and I enjoyed the opportunity to speak to you.